Hey everyone, and welcome to Holding the Line with Got Your Six Counseling. I'm Peggy, and this is Brittany. This is a space where we get real about the shit nobody wants to talk about: mental health, life, trauma, healing, and everything in between. Sometimes we get clinical, sometimes we get messy, but it's always honest. Quick reminder, this podcast isn't therapy, and it's not a substitute for professional care. We're not here to provide therapy, diagnose, or treat. If you're struggling with mental health, please reach out to a licensed provider. You don't have to go through it alone. We've got your six. We're just two trauma therapists showing up as humans first, ready to have real, unfiltered conversations about the stuff that matters. We're here to break the stigma, share what we've learned from both sides of the therapy room, and talk about the challenges people face every day, especially in the veteran and first responder communities. Whether it's trauma, burnout, relationships, identity, or just getting through the week, we believe that these conversations matter. They deserve space, and that's what we're holding the line for. So let's dive in.
Welcome back, everyone, to another episode of Holding the Line with Got Your Six Counseling. I'm Brittany, and this is Peggy, and we are on episode 11. Today, we are talking about red flags in trauma recovery work. Signs a therapist or modality may not be trauma-informed. This is not the first time we've talked about being trauma-informed. And this topic matters because a lot of our patients are seeking out trauma-informed or trauma-trained therapists. What's your take on this, Peggy? We were trying to, well, not really decide what we were going to talk about today, and this one kind of hit home because
it's not like one size fits all, but when you're coming from, I guess, specific populations, especially like our veterans, our first responders, if you're already coming in with a pre-existing like PTSD diagnosis, they're coming in for a specific reason, and it's because like other things haven't worked out, because too many therapists do like, I only do this, and that's fine. Like, if you have a strength in one modality, cool, use it. We love that for you, and like everybody has strengths and they need to use those. But when it comes to trauma-informed care, it is not one size fits all. We have to pull from a lot of different things. We have to pull from a lot of different modalities, and we have to be more attuned to the patient and their feedback of what their needs are.
fair enough. And I think that using the wrong therapeutic approach, especially with trauma work, can prevent them from healing, generally speaking. Like the therapists that are like, I only do CBT, or I only do this, or I only do that. And I think you have to be very much diverse, or, there's a specific word for it and it escapes me now. That they use in our grad school, they're like, you're this kind of therapist, right? Like, you use this type of, but anyways, diverse is the word I can come up with right now. To be able to work with different types of people, and especially in the trauma field. So I hope this doesn't show up in the podcast, but my thing at the bottom says recording ended prematurely. So I hope we're still recording. Did you get that message?
It's
Okay.
still
Cool. So, number one flag that we pushed, not say we, but like that therapist pushed too fast.
yes.
Pushes too fast.
Well, because in intake we're gathering like little tidbits and everything from them, so like we're getting snippets of their trauma, right? And then we go into session 2, 3, 4, and I think too many want to like fix it, and that I think is the common problem. We want to fix it, and we're not there to
Right.
fix it. Hey,
Yeah. It's tempting.
but we're supposed to be developing trust. We're supposed to be developing rapport, not how can I fix you right now. But even I think the patients have a misconception sometimes of, can you fix me now? Show me what I can do to be whole, healthy, and human again. And they're like, why am I not better after two sessions?
Yeah. I think for students, and we've talked about this before with our students, and I think with like baby residents, there is that drive to like do the helping and do the fixing very early on because you're eager to like do the thing. And I think with veterans and first responders, generally speaking, there's like that pushback of like, I don't trust you, or I need to be able to like know that you can do this type of work. Um, and some, I think we've heard some horror stories of like, they sit in with that therapist for the first time, and that therapist is like, tell me all your traumas. And we have like a visceral reaction to that. We're like, oh, why would someone do that? Right? Because you risk like the re traumatization of them. I will stop patients mid sentence when they start doing it. I'm like, pump your brakes. Don't do that. Wait, that's what we're not going to do, right? Like, please don't do that. And I think other therapists are just like, that's what we have to do. We have to talk about it. And that's only partially true, right? Like, we're not going to do that in here. And so I think other therapists will do that because maybe they're not emotionally ready
Well,
to go there.
especially in intake, because like we're not necessarily giving them tools to work through all of that in intake, and so
It's not what it's about.
and so they're like coming out of intake so emotionally dysregulated, and they're like, well, now what the hell am I supposed to do? And I'm like, oh no, because you're not supposed to sit there and just traumatize yourself through the entire intake. It's like, okay, so I have X, Y, and Z stress or distress or trauma, but let's not open the entire chapter necessarily.
Right. We need just enough, like on your history, just enough to make a diagnosis. Thank you, insurance, right? Because it's such a short period of time to make a diagnosis, right? If you have trauma, I really just need the thing, right? Like, I don't even need all the details. Like, is this what happened? And some people don't even give you enough for that in the first intake, like in the first session, So you kind of just have to go with what you got. Aside from that, I don't really need the whole story. We can get to that later, you know? But some people really do. They're like, I need all the details. No, you don't. Not in the first session, because then they're waiting a week
Or
for the next
or
one.
what was the best one that wanted to make a whole slideshow?
Yes, yes. When I was intake coordinator, we had someone who was like, can I just give you a slideshow of my trauma? And I was like, low key, I kind of wanted to see it. Like, I was super curious. And also, no, absolutely. Why? Why would you want to do that? Like, why would you want to traumatize yourself in that way of like giving us a slideshow about your trauma?
Let
Also,
me save you
how
time.
awful would that be? Right? How awful would that be to like make it for yourself? Like, can you imagine making a slideshow of your trauma?
Well, let me show you my childhood and let me show you my adolescence. Like I can, like my brain works in that way, and I could totally do it.
Right. It's like a flow chart, right? Like, this is a flow chart of my trauma.
Here's where it started.
Right. Like, I saw that meme that was like, if I lined up all my dating history and my exes, you could see a flow chart of my mental illness. And I was like, yeah, that's fair. Maybe not so much trauma, but like your mental illness. But yeah, pushing too fast, right? Like, not giving people the space to like process things. And I think that's another key point, unless we are going to do deep like EMDR work, or for people that do brain spotting or something like that, there really isn't any need to like deep dive into the main details of your trauma. We're not going there.
I think EMDR, especially when you're doing
Especially,
like intensive, that's like a hard and fast ride,
yeah,
and that's why I don't do intensives. But Christina
right.
does, and like that is
I'm ready to get there.
that is that emotional rough ride where you are just going to lay it all down. But after you have done enough psychotherapy beforehand.
Yeah. I think that's the misconception of like, you have to talk about your trauma to get through it. That a lot of people think you have to do, right? Like, oh, I have to tell you all these things about what happened to me. Um, and I don't know that that's entirely true, right? Like, that's a very like narrative exposure therapy belief that just doesn't necessarily work, right? Like, no, we're not going there. Because what we don't want to do is re-traumatize you, unless we're going the EMDR brain spotting route, where you've got someone highly trained that's going to help you reprocess what happened. Otherwise, we're just reliving it over and over again. For what? For why?
No.
Right? which then leads us into the next one where they
Skipping.
are not stable enough and they're skipping that whole stabilization process because they have no emotion regulation.
Well, I think this is part of the like why we don't like jump off the bat into like CBT and stuff like that, because most of these people are not stable enough for CBT. How am I supposed to concretely think about something if my emotions are dysregulated and all over the place?
Right. There's nothing there, which is why DBT works so. And they all have these negative thought processes and these cognitive distortions about themselves, right? Like this black or white thinking, or they're predicting the future, right? I mean, or what's the other one where they're okay, anyways, I can't think of the word, but everything is gonna go bad, right? Like
Mm-hmm.
nothing is good, everything is bad. That's not true. You can't ever say that that's true. You can't predict the future. Stop it. It's not gonna happen. We're not mind readers, okay? Are you psychic? Please.
But a lot of them think they are. It's okay.
They're like, I'm waiting for the other shoe to drop, and I'm like, it's not gonna. It's fine. We're living for today. Stop. Right? But they can't do that. Cognitively speaking, everything has always been shit and it always will be shit. So until you can get them regulated enough, that's where they're going to live.
Mm-hmm.
Right? So, like Becky said, they're not stable enough for it. And until you get them there, that's where they're going to stay.
And
That's why I like using DBT.
but stabilization looks different for everyone also. What is good for one person might not work for the next one. So like DBT might work for that person, but another one may really thrive more in like mindfulness and more grounding and those kinds of things. It's again, it is not one size fits all, and we never want to make it one size fits all.
Right. Yeah. And that circles back to the pushing too fast. They push too quickly on the processing and the exposure stuff, which
No, no.
don't even get me on my sandbox about the exposure. No. We don't do that here. I don't do exposure work.
I
Why are
have,
you looking at me like that?
because I know Christina's stance on exposure. I have seen all of our stances on exposure, because exposure, I understand those that do it, but I also understand why we don't, because exposure can be dangerous on the wrong person.
Well, yeah. And with our population, 100%, right?
Yes.
We're not talking about somebody who's afraid of spiders and giving them like exposure to spiders or the dark, right? Like this is a totally different thing here. And even that feels a little bit cruel, right? So this is not quite the same thing, but people jumping right into that without any type of regulation is almost harmful, truly.
It is harmful.
Yeah. Well, yeah. But you've got people out here doing it. And they're like, no, this is fine. This is what they need. Not at all. Right? Like, even if you're using like the basic stabilization techniques of EMDR, or like you said, simple grounding or mindfulness, progressive muscle, anything is better than nothing. Why are we out here just raw dogging it?
Because again, we get all of this knowledge and then just expect to like go forth and do the work, and it's like, okay, no, we have to work on a patient's timeline, not our timeline.
But then you have those patients that come in and they're like, I don't want to do that. That doesn't work for me. I want to do something different, right? Like I've tried it all, right? Which then presents a challenge for people like us, because sometimes our patients have like run the gambit of like through the VA system or other, community care people, right? So then you're presented with the challenge of like, well, what am I going to teach this person? Where do I go from here? And then they're very resistant to like EMDR or other, hardcore interventions. So then it leaves like, where does that leave you? What are you going to do?
Sometimes they just need someone to sit with them too. And I think that's like the first rule of Fight Club is just sit with your patient too. Stop trying to
We don't
fix.
talk about it.
Stop.
Right.
Yeah. Stop trying to fix them. let them lead you instead of us trying to always lead them.
Right.
It's like, I'm going to start first
Because
rule of
this whole
counseling.
time, yeah, yeah. First rule of counseling, Fight Club, right? Maybe we should have called the podcast that Fight Club, Counseling Fight Club. Yeah.
Stop trying to fucking fix them.
I mean, I think they've just been like through so many different types of counseling where people were trying to fix them that they're just looking for someone to just sit in that space with them, like you said, to like hear them out because every other place they've been to has been like, "Ooh, try this, and this, and why isn't that working for you?" And and then they've been in group therapy sessions where they're like, "Oh, let's talk about all your traumas and let's share it with a group of strangers," and they're like, "I will not be doing that, thank you."
Why do we want to put a bunch of people with PTSD in a big group? It's like, why? That seems horrific.
With zero stabilization, again.
That seems horrific because I'm like, wow. And everybody's just telling war stories to each other, especially a VA PTSD group. I'm like, that doesn't sound good at all. And then they just sit there and complain about the VA.
Right. Right. I would rather put a campfire out with my face than sit in a group circle and talk about my trauma. And I'm not even a veteran. Like, I don't want to do that.
Oh, gosh.
You know what I mean? Absolutely not. Absolutely not. That's a hard no.
And then we have, and what we're looking for in clinicians, especially the minimizing or dismissing of trauma. The symptoms specifically, like therapists that downplay your reactions. It's not that bad. Just think positive. No.
I hadn't thought of that.
If I ever had someone tell me, if you would just think positive about that, I might punch someone.
Just avoid those things. Just don't go here. Just don't do that. You just have to move through it. You just have to forget about it. Here's my favorite. The past is the past. Or just pray about it. You can have Jesus in therapy too.
Mm-hmm.
Not to delineate or say that that's not okay, right? Like you can find strength in religion and spirituality. However, science.
Mm-hmm.
Science.
Or minimizing what you're going through, especially the big T's, right?
Yes.
Yeah, but it's in the past. Okay, what are we focusing on now?
Doesn't feel like it's in the past to them. Yep.
Because once they get comfortable enough to start telling you about what heavy things they are going through, what we're not going to do is minimize those heavy things.
Right.
Or even the things that don't feel like they're that heavy, but we sit there and go, okay. Especially the ones that like to go, well, my childhood was like this. And we're sitting there going, huh?
No, my childhood was normal. And then I'm like, oh, tell me about it. And they're like, well, my mom used to hang me out the window by my feet. And I'm like, you don't say. And they're like, yeah. And my dad used to beat me with an extension cord. And I'm like,
but it was normal. It was great.
And they're like, but that was just how things were back then. And I'm like, oh, okay. And then 8 months down the road, they're like, yeah, I guess my childhood was pretty abusive. And I'm like, oh, okay. We're here now. Right? It's minimized, right? Like, because people all their lives and maybe therapists they've visited are like, oh, you just got to move through that. That was just the way it was, right? But that's also generational, right? Like our generation is very much, we're not repeating generational curses. Or generational trauma, right? Not curse, generational trauma. But the generations before us are very much like, we leave the past in the past. We're not airing our dirty laundry. And whatever happened, you just have to move through it.
Mm-hmm. And we don't treat symptoms as character flaws.
Yeah, not us.
Other people. Feelings are valid. Doesn't matter. Feelings are valid. Now, can we get on that the tone and tenor have something to be said for, but feelings are valid, right?
Yeah,
We will never
for
apologize.
sure.
We do not apologize for feelings. Anger is valid. Sadness is valid. Joy is valid. All of it.
I do think there's something to be said about like anger, because
Mm-hmm.
you and I agree on this, that anger is such a powerful emotion that generally speaking, there are usually like really big emotions hiding behind anger. Um, which I think a lot of therapists don't explore because that's scary.
Anger is protective.
Anger is protective. So while it's valid, there's a lot of big stuff hiding behind it. Um, and I think circling back to like the what was I? Look, my I feel like Tuesdays are not good days to like record because I'll have a thought and then it goes away. Oh, like the past is in the past, right?
Mm-hmm.
Ooh, that came back quick. I'm so proud of myself. The past is in the past. Science moment. The adaptive information processing model of EMDR says that the past always becomes the present. So when you look at someone and you're like, the past is in the past, Karen,
No.
it very much feels like the present to them because when they are like when they experience something that feels like their trauma, it is very much in their face right now because their brain does not know the difference. So don't be a douche and say that was years ago or that was however. No, be a nicer person, whether you're a therapist or not. Don't be that guy. Okay, sorry, moving on. You know, I had to get like my little education bit in there. Okay, I don't like it when people are those people, you know. um, so right, rigid one size fits all modalities.
Listen to your people. Listen to your people. If they say, I don't like this and I want to move on to something else, that's okay. It doesn't make you a bad therapist. It doesn't make them a bad client. They just want something else.
Or you're not noticing progress, like maybe it's time to switch gears. If you've been at it for like 8 months and there's nothing happening, maybe that's not the one for them.
Because not even everything that you do, like, what is it? Not everybody, just not everything you do, they're going to like. I'm a very partsy person, and guess what? Not everybody likes that. Some people are absolutely like, dude, They will.
Or they don't respond to it,
Uh-huh.
or they go too far into themselves.
And or they're just like, no, just switch it up immediately. Like they don't get the buy-in, right? And some things do take a buy-in. EMDR
Yeah.
takes a buy-in. That one will make people run for the hills so fast. They're like, nope, that's uncomfortable.
Yeah. Usually, though, I feel like with EMDR, either they had a bad experience or they've read too much online about it, or like you start with them and they get freaked out and they're like, I'm all done. Right? Like, I'm like, stay off the internet. Stop it. And they're like, well, the internet said, I'm like, so everything you read on the internet's true? Stop. Experience it for yourself. And like, well, I had a bad experience. I'm like, well, you probably had a crappy EMDR therapist. Okay, stop. Um,
Because and the whole session isn't going to be just in that modality either, right? Like,
no.
it's okay to like take a snippet here, take a snippet there of all the things that you like.
Right. And I think some, some were very rich, like DBT traditionally is super like structured rigid. CBT is too, right? Like, well, they're, very similar. But like if you are hardcore, um, what does Christina call it when you're DBT? Like you're a
Purist.
true purist, a DBT purist. You are very structured. You are very rigid. Like you start here, then here, then here, then here, and you get lots of homework and it's lots of paperwork. But if you're not a DBT purist and you just kind of jump around, I kind of jump around, right? Like I'm like, I go based on the need, right? Like if they're coming and I'm like feeling like maybe they need distress tolerance, guess what? Who's getting taught distress tolerance today? That person, right? Maybe they need radical acceptance. Maybe they need this. Maybe they need that. I am not going down the timeline. Maybe that's wrong, but that's how I roll. You know what I mean?
Mm-hmm.
Maybe they need to be taught how to cognitively challenge. Maybe they need this. I am all over the place. Maybe I'm feeling like they need some motivational interviewing today, and that's what they're getting. And that's all about being diverse and choosing what they need in the moment.
And it's okay that your therapist challenges you.
It is.
They're supposed
If your
to.
therapist is not challenging you, you need to find a new therapist.
Like, if they're just there, like, more or less stroking your ego and stroking, like, your feelings that you have and be like, everything's okay, you're fine, nothing's wrong in your life, and no. They're there to challenge you and some of what's going on with you, and it gets uncomfortable.
Yeah. Your therapist should be making you feel seen. Like, you should be, like shifting in your chair and, like, I don't like you very much. If you've never looked at your therapist and been like, I don't like you very much today, that's a problem. I tell my therapist all the time, I'm like, I like you very much. I hope she's watching this. Like, I hope she's going to see this later. I told her last week, I was like, you're making me feel seen and I'm ready to go. I was like, I don't like this at all.
Mm-hmm.
One of my patients today told me that. He was like, I don't like that question. I was like, good. That means I touched a nerve and I'm doing my job, right? That's the point of it.
Yeah. Get uncomfortable. If you're not ever uncomfortable in therapy, where's the work?
Discomfort brings change.
Mm-hmm. No.
Without it, what are we doing?
Yeah. And, like, have some integration. We have to use some body-based stuff. Because
It's all in the body.
this affects all of this.
And when this is disconnected with that, where does that leave you?
Dissociating.
We got to get that connection back together again. And I think a lot of people who claim to be trauma informed don't actually understand where that disconnect comes from, right? Because they're like, well, I know it here, but this is happening. And I'm like, right, well, they're not together anymore. They're on different wavelengths.
And have your therapist explain some things. If you don't understand it, ask about it. Psychoeducation.
And if they can't explain it, that's another red flag.
Because psychoeducation is important. You want to know why your brain is ticking the way it's ticking? Ask.
Yeah. If they can't explain amygdala hijacking or fight or flight or the triggers and the activators and stuff that you're experiencing, or they're like, why am I like this? And they're like, well, that's a red flag. Get out right now. Just pick up your stuff and run away. Because anybody who is trauma informed or trauma trained or whatever they're claiming to be should be able to spit that out in a way that you can understand. And if they can't, that's a red flag. It's not on here, I don't think, but that is a red flag I'm adding right now. 100%. They should be able to tell you all those things.
Well, we're big into psychoed too.
I know, I have a hard on for it. Big things to come there. You know, I feel like people feel validated when they understand, right?
Exactly.
Like, because how many people have come into your office? Well, not literally into your office, but stepped into your virtual room and been like, why am I like this?
Mm-hmm.
Right? I need to understand why I'm like this. Why do I feel this way? Why does this happen? And you're like, well, let me tell you. I do the same. I'm like, let me tell you why. I will draw whole diagrams. I'm like, this is why.
Oh.
I have actual graphics. I'm like, this is your brain. This is your amygdala.
I love to show them the differences, like, between this is your brain on trauma, this is your normal brain. I'm like, you see how this is lit up like a Christmas tree?
Mm-hmm. Yep. I have that slide saved on my iPad, and I'm like, look at this. Do you see the difference? I won't tell them which is which. I'm like, which one do you think is a normal brain? I'm like, quiz, test time. You know.
And most people would choose the one that's not lit up like a Christmas tree because they're like, it's the one that's dead. I'm like, no.
Yeah. See, most people think that the quiet brain is the one with PTSD, which I think is interesting. They think that that's the one with the PTSD instead of the, I hope Christina puts that graphic on here so people can see. Hint, hint. Throw that up so people can tell, right? They choose the quiet one because they think, oh, it's like dissociative, it's quiet. And really, it's the crazy lit up brain that's like, no wonder people are so tired. No wonder they're fatigued.
Because it's
Which was very
constantly,
shocking
yeah.
for me the first time I saw it. Yeah,
Yeah.
they're on guard. They're in survival mode.
It's constantly
How
firing.
exhausting to live like that. Yeah,
Yep.
um,
But
for sure.
having someone be able to explain that to you does a world of a difference. Because,
Yeah.
why is my amygdala firing? Where is my amygdala located? No, you cannot take it out. You have two.
I mean,
I have had that question several times. They're like, is there a surgery for this? No.
I don't think anybody's ever asked me
I've
that.
had several.
But I feel like now that you've said it, someone's going to ask and I'm going to be like, no.
That you have two of them. And they're like, why? Why? I would like to get rid of them. I understand. I understand this fully.
I mean, you know what? It wouldn't be the craziest thing someone asked, I feel like.
I mean, it beats the whole, can we go back to lobotomies?
When I sign into my therapy appointments, I put in the most outlandish things in my name.
Mm-hmm.
That was one of them. I was like, lobotomize me, please. She was like, really? I was like, I just have to shock you every time I come in because it gives me joy. Um, you know, we talked about this morning about ignoring culture and identity, and we were very on our soapbox about it in a different context. But also, this is important because, most importantly, for our population, the military and first responders, the military in and of itself has its own culture, right? Like, if you are not aware of that, it does. There are actually books written about it, about how it's its own culture. I feel like first responders probably have their own culture up here, right? Like, truly, if you're a part of it, it definitely does. But also, like, race and gender and types of trauma you experience, right? Truly. And ignoring that does them a disservice in the trauma world.
Yep. And if they are not culturally competent, what does that mean for you?
Why'd you say it like that?
Because I think that's one of the big things is out there is like, what is cultural competence? Because like it can go through like all the different categories, whether it is military, whether it is having someone know what diverse backgrounds are, like all of the things. And it's okay to walk away from someone that isn't fitting your needs.
Yeah.
Because there are some out there, and that, again, they only work with singular populations.
Yeah.
And it's because they're niche-y. Fine. Cool. But also, that's pigeonholing yourself.
Yeah.
We need to be a little more broad-ranged. And if your clinician isn't competent about you, your backgrounds, or doesn't even want to make the effort to get to know those backgrounds, it's not for you.
Right.
Because it's one thing to like we're going to have babies and stuff like that have no military background whatsoever. That's fine. But there has to be a concerted effort to get to know what it is.
Right. When I sit with veterans all the time,
Mm-hmm.
I have primarily veterans, and I'm like, was I a military spouse for most of my life? 100%. Do I know what it's like to be a veteran? No. I will never, ever know what it's like to be a veteran. I will never know what it's like to to be in your shoes.
Exactly.
Right? I'll acknowledge that. I sit with people of a different racial and ethnic background.
All the time.
Never know what it's like to be you or to have your experiences. But can I sit with you in this moment and try to understand? Sure. Can I listen with everything I have to try to like, empathize, all the things, sure. Right. And look, those words are confusing right now because it's late in the day. So just work with me here. Okay. Um, but I think people that are just like, right, like they don't even take a minute to try to understand, or have these like little microaggressions about the things that people are going through or the kind of people they are. That's the kind of people you want to move away from.
Well, because then it's no longer empathy, right? We've moved away from it.
We moved away
Of
from that.
being able to sit in the space with your patient and try to get down in the hole with them.
Yep. And the ones that are very, I want to make sure I use the right word here, um, unempathetic towards trauma experiences based on the population they're working with. Okay, I think I said that right. And by that, I mean like they are doubtful about whether those are experiences are true. Does that make sense?
Yes.
I hope that's true, right? Like someone comes in and they're telling you about this and they're like, I don't know that that really happened. It's not your job to determine whether that happened or it's true or not, right? Like if someone's coming in and telling you this happened, then it happened, right? And your job is to just deal with it, right? I don't know if that falls in line with cultural competencies, but just do it, right? Like they're telling you this happened, it
Yeah.
happened.
Because
Do the thing.
because they're not, again, they're not doing what a therapist is supposed to be doing, which is just sitting there and freaking listening. This is the patient's lived experiences. We are not here
Yeah,
to judge the lived experience.
right, right. Or like, oh, that couldn't have been that bad, right? And how could that have affected you? How could that be traumatic? How could that have affected you so much
Or because they're taking that the
from
therapist
their own
or the
experiences?
therapist knows best stance. That's not supposed to
Right.
affect you in that way.
Not at all.
You don't get to tell someone what affects them and what doesn't affect them.
Right. No, not at all. Just because you as the therapist have the tools to regulate and acknowledge and see doesn't mean that they do.
It,
Never, never.
and if your therapist does not involve you in goal setting, keeping the pace, or the direction of therapy, ditch it. Especially goal planning, your treatment reviews, you should be knowing what are we doing good? What are we not doing good? What changes do we need to make?
Right. How do you feel this is going? Right? What improvements have you made? Right? Like, I ask in the first session, like, where would you like to go? What is this? I'm saying, like, what goals do you have for therapy? Right? It might not be the actual goals we're writing, right? Because those are more clinical in nature, right? This is more, here we go. But I want to know what you hope to gain, right? Like, what are we going to work on? And usually those align with what we're writing too, right? Like that's what we're doing. But at the treatment plan review time, I'm like, how you feel? Do you feel like you've gotten better, right? Because why wouldn't you involve them?
Progress. What do you think you're doing good? Okay, where do you think we're not doing good? Like those are valid questions. Ask them.
I feel like a lot of times too, they don't give themselves the credit they deserve, right? Because they're like, I'm like, how do you feel? And they're like, I haven't made any improvement. I'm like, really? Because
I'm
I don't feel like you're giving yourself enough credit.
yeah,
I
I'm bad.
tried.
I'm bad. The world's bad. Everything's bad, and
Right.
everything's on fire. And I'm like, okay, but like here we did good, and here we did good, and here we did good, and
Yep.
so like, is everything bad?
Yeah, I'm like, so you've reconnected with several family members you were no contact with, and you've been doing this, and your relationship with your wife is better. So, like, are you still forky, or like? And they're like, okay, yeah, I guess I've been doing pretty good. And I'm like, okay, good, yeah, because that's what I'm seeing. So stop going forky on me,
Yeah,
please.
I'm.
Like,
I'm like you're able to talk about this without breaking down every time. Yay,
right.
you.
I'm like, don't give me imposter syndrome here. Like, we're doing good, so let's pump your brakes. Don't make me call Christina. I don't need to have a meltdown too. All right.
This one, poor boundaries, and emotional reactivity. Okay, there's no. It is one thing that a therapist gets emotional in a session. I have cried with my patients, and that is that to me that shows again that empathy and that being there with them and being able to take in, because like we're taking in parts of them all the time. We have to take a piece of them during that session and try to be able to hand it back to them, and sometimes that is rough to do.
Yeah.
And so, and I know it is, some professors will really frown on that, and it's like, don't do that. Don't be emotional during your session. It's okay to have a reaction.
I'm not a robot.
Mm-hmm.
Right? Like, I'm a human too. So I'm allowed to have emotions. I remember there was a clinician that used to work for us that came into Christina's office one time after a session, and she was just like, her face was all red, and she was like, I feel like such an awful like therapist. Like, my patient came in and she was talking about something, and it just like, it was just so sad, and I just cried and cried with her.
Yeah.
And Christina was like, okay, and she was like, I just felt like I shouldn't have done that. And there was a couple of us sitting in her office, and she was like, what do you think? Do you think that it was okay for her to cry? And I was like, why not? Like, she's not, I was like, she's not a robot. And she asked the other person, and I think somebody in there disagreed. And she was like, it's 100% fine to cry with your patient. Like, you are not a robot. You are human. And it shows your patient that, like, you are connecting with them on that level.
Mm-hmm.
Cry with your patient.
Yeah.
I've gotten teary a couple of times. I think I've gotten choked up, but I haven't, like, actually cried yet. So,
Like, are there times when it is hard and we become, like, dysregulated ourselves? Absolutely.
oh my God.
But if your therapist is cursing you out,
Jesus.
I've heard horror stories. If they are becoming emotionally dysregulated to the point that it is uncomfortable, then we can ditch it. But they are human, and they are going to react to some things. We're going to have facial expressions. We're going to have all of the things. And like, because again, we're in the moment with you. And sometimes we're celebrating with you, and we're going to be expressive. And like Brittany knows, my facial expressions are always on point, whether I'm like,
Fix your face.
I try not to do that one.
I think it's important to differentiate, because we're talking about crying in session with our patient.
Mm-hmm.
We don't mean we're crying because of our own shit.
No.
Okay? Like, we are crying, we are feeling our patient's emotions and reacting to that with them, right? I hope that makes sense. We are not crying because our patient's emotions and trauma has triggered some type of trauma of ours, which is countertransference.
Mm-hmm.
That's not what we're talking about. If your patient's trauma is inciting some trauma inside you, that is what we're talking about. That is the red flag that we're referring to.
Yep.
And that means that you need to go do your own trauma work, because you haven't addressed that shit yet. Okay? Like, that is the red flag that we are talking about here. Okay? So I hope that's cleared up.
Yeah, but speaking of that transference is when your therapist starts talking about if they talk about their own trauma. It is one thing.
Or they're talking too much about themselves.
Because it's one thing to give like limited disclosure to make relatable things. It is another thing to take over your session and make it about them, and you have now become the therapist, which you are not supposed to become. Because then I wish a client would, if somebody did this to them, if they took over the session, be like, I will charge you $140 now.
Where's my bill? I think self-disclosure, generally speaking, is a hot topic, but when it comes to this, it's definitely more like toeing the line, right? Because they very much like, don't self-disclose, don't talk about yourself, like in grad school, right? And then I think it's up to every clinician, like how much they want to self-disclose. I think if you don't ever self-disclose anything about yourself, you become very closed off, and your patient's like, well, I don't know anything about you, right? And when you've been seeing people for years and they don't know anything about you, they're very much like, you're a stranger to me, right? So there is some level of self-disclosure you have to have with your people. But when you're sitting there and you're like, oh, these are all my traumas. Why would you know? I would never, right? Could you sit there and be like, am I a trauma survivor? Sure, right? But you should not be sitting there telling your patients your trauma specifically.
That's weird.
Why would you ever want to do that? It's weird, right? Is it validating to know as a trauma survivor yourself, as a patient, that your therapist is also a trauma survivor? Sure, right? Is it validating to know that your therapist, who is a trauma therapist, that is trying to do or not wanting to do EMDR with you, also had EMDR? Maybe, right? I know what you're going to go through because I've been there. Why not?
That was,
right?
Yes, especially because I will tell them, you know what, we had to do it in training to ourselves. So I know what this ride looks like.
I did that, and I had years of EMDR done on me, which was awful. But I will never ask you to be like, I've done that myself, right? So in that terms of that, that's different than being like, wow, I know what you've been through with this awful experience.
Here is my own personal experience, and let me take over the next 15 minutes talking about it.
No. Out the door. Immediately to jail.
Start giving everybody little red flags to carry around. Here you go.
I would.
The red flag guy.
Yeah. Christina, run him across the screen. I have football red flags here in my office that I just need to start throwing, like red flag. I wish I had them ready for this because that would have been hilarious to just throw it. Yes. When they become visibly, did we talk about visibly uncomfortable and emotionally dysregulated? We haven't got there yet because, oh my God.
Yeah.
I don't even know what else to say about that.
That's what I'm saying. Like, if your therapist, it's okay to get uncomfortable because, look, we hear things. We hear all the things, actually.
If these walls could talk, right?
I think there's a fine line becoming uncomfortable because, again, we hear the things, but don't make it so known to, like, it makes your patient uncomfortable.
Yeah.
Because they know what they are saying is distressing and that it's uncomfortable for them. And if they are really just opening up for the first time about it, you showing your uncomfortableness with it, fix your face, fix your body language.
Right. Well, and if they're also dysregulated and uncomfortable and you're mirroring that, I think that's one thing, right? Very different from like you feel unsafe. We're not talking about that, right? Like if you're feeling unsafe, that's a totally different situation that you can end it and move on with your day. I think this is very different in terms of what Peggy's talking about, where maybe what they're saying is activating you, triggering you in some sort of way, and you are visibly shaken. It's only ever happened to me that one time. We've talked about that before, where I was like, control yourself.
And it's hard to, because like some people, again, because some therapists have their own trauma background, and it's like that one thing activated them. It's like, oopsie, butterfly, tap my leg or something into like, I need to, anything. It's like, hey, I need you to go take a time out for a minute. I will deal with you in a minute.
I think that's why it's so important to like have your own outlet when it comes to like therapy too, or like your own little way of like grounding yourself in between, right? Like you've got to have your own little structure, routine, whatever you need. If you got to go outside and like bury your face in the grass or something, I don't know. I always joke and tell people to go outside and touch grass. Like you've got to have something, because some of these sessions, like what does Christina always say, that they take a little piece of us every session takes a little piece of us. Our patients take a little piece of us every time, every day. It's true, right? Like they leave and there's another piece of us gone for the day, because, sometimes it's really, really heavy stuff, and maybe you are dysregulated. Maybe you're not until it's over. I had that little girl, a little girl, and I just went home and cried after. And like it didn't bother me in the session, but afterwards, like maybe it's delayed, right? And there's nothing wrong with that, right? Like in the moment, I think we get very good about detaching, but it catches up with you later. And maybe that's it, right? That's all normal. But when your patient is noticing you becoming dysregulated and uncomfortable in the session, and then they're mirroring that and they see that, then that makes them feel like they're bothering you in some way, right?
Yep. So, what are we looking for when it comes to a therapist that is trauma informed specifically?
We're looking for someone who fosters that safety that they're looking for. Because how many of them talk about how they feel so vulnerable all the time? I don't feel safe in my relationships. I'm looking for someone that I can trust, which although also, by the way, might take years to develop as a therapist. How many of your patients have you been seeing for multiple years?
I have some of my OGs that I have.
Same. Since I've had some I've been seeing since I was a student,
Yeah.
right? And how long did it take you to develop that trust with them?
Yeah. Long time.
So long. So long, right?
But that, I think
want-
that's the big thing is because, like, they want to feel respected, not judged. And it takes a lot to get through the layers.
They're onions.
They're onions.
They're onions. Some of them are like the big onions you get at Outback, right? Like the big, giant blooming onions. Not like the little baby onions you cook with, okay? We're talking like the big ones. I don't mean that in a bad way, right? Like, I'm just saying, they've got lots of layers, okay? They want to be paced. They want to take their time. And so you have to be very patient.
Yeah.
Patience is the virtue.
Your therapist wants to work with you, beside you, not just because I think that's a huge thing, and it always has been for me. It's like I'm here to work with you, not this feel like it's very one-sided, especially because I'm doing it through a screen all day long. And so, like, I constantly feel like I'm talking, I want them to feel like they're not talking at me.
Right.
And, like, so for the conversation to feel more genuine and everything. That's why I think I'm a little more expressive with my facial features and stuff like that. Just because, like, it's to make a connectedness.
Is that why when you laugh, nothing comes
I
out?
think so. But I'm like that at home anyways, because, again, that's my own stuff. I've always been like that.
That's so funny to me. It's like you make the expression, and I think you're gonna, but nothing comes out.
I'm like that in person.
Sometimes we get a sound. Okay, you said respected, not judged or rushed. Being taught some stabilization things early, being able to emotionally regulate early because maybe you haven't ever been taught that. And most people, I think, with trauma coming into therapy are coming here because that is one of their biggest issues.
Yeah.
They are so emotionally dysregulated that they cannot function anywhere.
That you feel
They're irritable, they're angry,
Yeah.
they're frustrated, right? All the things. They
that
can't sleep.
that as a therapist you just listen, because for a lot of them it is the first time that they're just getting it out and not playing hot potato with therapist.
Right.
I feel like I've got some that have been through there, like done this, I've done that, I've done this, and I've done that, and I'm like, slow down, just sit here for a minute, just talk,
Yeah.
and that's okay.
Also, I think being consistent,
Yeah.
right? Like, I'm going to see, like we do, right? Like, I'm going to see you on this day at this time every week or every 2 weeks when we get further into it. But, like, some need it twice a week, right? I have a couple that I see twice a week. Maybe two or three that I see twice a week, right? But that consistency, because up until now, they might not have had that, right? Like, if they go to the VA, they're like, I don't want to go to the VA anymore because they can only see me once a month or every 3 months. Like, You cannot complete anything in that amount of time.
Yeah.
You cannot, a treatment plan's every 90 days. You're telling me that you're going to see someone once a month or every 2 months. What are you even accomplishing in that amount of time? Nothing.
Showing up knowledgeable, because we never want to see anybody pull out a binder of how to treat PTSD 101.
How many times have we brought that up in this podcast? Because I feel like it is such a Roman Empire for us. For like,
I want to see the binder.
who has the audacity?
I want to see the binder.
The audacity of someone, first of all, to create a binder that's like how to treat trauma, and then to like pull it out in front of a patient, just like makes
I'll never
my
forgive
blood
the
boil.
VA for that.
We're just gonna call them out right now. It was the VA. Okay, it was the Department of Veterans Affairs in Richmond. I'm sorry to throw shade. It was them. DC probably has one too, right? I'm so sorry, but I'm not.
Mm-hmm. And then that your therapist doesn't rush you to get better, like, because I know we have this problem, like, just with the VA specifically. You're not supposed to get better in 12 sessions.
No.
That nobody's rushing how quickly you get better.
You could have all 52 sessions in a year and probably still not be better.
Mm-hmm.
It took you years and years to become this way, right? And it's not going to take you a year. It's not going to be better in a year. It might not be better in 2, 3, or 4. I've had patients for 4 years and they're still not. Are they significantly better? Are they significantly improved? Sure. Are they 100% better? They might not ever be 100% better.
Yeah.
So knowing and sitting with that might be the most important thing, not the most important thing, but one of the most important things to acknowledge. That, like, you might fit this criteria for a long time, you might drop down below it, but like, this is always going to be something you're mindful of and working to prevent relapse of these symptoms, period. Okay, just like if you were an alcoholic, right? Like, you're always aware of it, you know.
Mm-hmm.
Always. What else we got? What else?
We love this conversation. Come on, trauma-informed care has always been our...
So many people claim to be trauma-informed or trauma-trained, and they're really not, right? Like, it's such a lie they tell themselves and other people, and then people go into therapy with them, and it's like family members. So many people, they go in, and I'm like, what? They did what? And I'm like, absolutely not. This is up to you to continue if you want to do therapy with them, but I am telling you that it's not good. That's a red flag. Immediately to jail. And they're like, I like them. I'm like, okay, that's fine.
Yeah.
But if you are hailing yourself as trauma informed or trauma trained on your psychology today, you better be able to back it up.
Yep. Talk the talk if you do this.
Mm-hmm. Yep. And also, if you check every single box on psychology today, you better back that up too.
You is a liar, first of all, because nobody does everything. Nobody does everything.
You cannot know everything.
You do not do all the modalities. You do not work with everybody. Stop it.
Unless you've been a therapist for like 50 years, then I don't believe it.
I feel like that if you've been a therapist for that long, you are picky. You are picky and you have the right to be.
100%. 100%. Legend. I hail you. You feel me? I think that, final thoughts, okay? If you have a trauma history in any capacity, I'm not throwing shade on the Walking Well therapists, but those are not going to cut it for you. Mm-hmm. Because you have to look at things through a trauma lens in order to treat trauma, and they're not going to be able to do it for you. They'll likely refer you out anyway. Of course, in this day and age, most people have some sort of background in treating trauma to some degree, but you want someone who specializes in trauma to help treat you. Period. Look them up. Search them out.
Exactly.
It is not optional. ever. If you need help, Psychology Today lets you. Again, I'm going back on my Psychology Today thing. Your insurance helps you too.
Get what you need
Go ahead.
to get the help that you need.
Your primary care doctor can help you too. Period. Any of your physicians can help you find a therapist. And if you're not happy with them, find someone else. The therapist that you engage with that you don't like should be helping you find someone else if you don't like them. And if they're not, and that's another red flag. Because if I have a patient that doesn't like me, or we don't feel like I say he, but they don't feel like we vibe, I'm like, bet, I'll help you find another one. I am not offended in any capacity because I know I am not everyone's cup of tea.
Here's your referrals.
Would you like a man or a woman? Right? Okay, you want another woman or you want a man? Got it. Look at all these in your area. Virtual or in person, right? I got you. I have no problem with that, right? Because
we have them where
I'm too abrasive.
We have them where they pass off at the practice. We're not one size. We are not one size fits all.
Yeah. If after 90 days, 6 months, even a year, I feel like, we're not moving in the right direction or things aren't going well, I'm like, listen, what's happening here? I'm like, do you think it would be better to shift to another clinician? Like, is it me? What's going on? Like, I'm real quick to confront, and not like in a bad way, but like, I want the best for you. It's not about the way I feel. I want you to feel like you're making progress here, like, forget my feelings. I want you to do better. And that's a good therapist. I'm not trying to toot my own horn here, but like, a good therapist is going to put their feelings aside and make it about you. Right? Maybe it is me. Maybe it's you. Maybe it's both of us.
Is it me, Jesus?
Is it me, Jesus? Am I the villain? Probably.
Mm-hmm. Mm-hmm.
Or the Taylor Swift song.
Exactly.
It's me. Hi. I have the problem. It's me. So, patients deserve us that are going to do what we say we're going to do. Unless I forget to send you the thing I told you I was going to send you. I'm so sorry. If you're waiting on something from me, I promise I'm getting there. All right. So don't judge me on that. But generally speaking about trauma work, yes. If we say we can do this thing, then we should actually be able to do that thing competently, period.
Please like, share, and subscribe. Follow. Not aggressively follow. Brittany.
Aggressively follow. And if you are family and friends of us and you are not, I am so disappointed in you. I can't even.
Don't shame people.
I want to thank you for tuning into this episode of Holding the Line with Got Your Six, where we are just a bunch of therapists who talk about the shit nobody wants to talk about. We hope you got something useful out of it. Stay tuned for more of our upcoming episodes every other week posted to our YouTube channel, Holding the Line GYS. If you want to help support our podcast, please like this video and subscribe to our channel and share this video with others you think may get something useful out of it. Make sure to follow us on Facebook and Instagram, where we will post useful information, dark humor, and more of the shit nobody wants to talk about. Go forth and do magical shit, everyone. I am shaming. I am shaming. Insert Game of Thrones, shame. I wish I had a bell. Shame. Like, share, and follow. Because it's just outright rude at this point, okay? So like, share, and follow. Thank you for watching, those of you that are consistent and love our videos, because you guys are gems, okay? So this is episode 11, Red Flags and Trauma Therapy. If you need help looking for a therapist, let us know. We'll help you because we're fun and we're cool. Thanks for watching. Enjoy. Stick around for the next one.
Bye.
We'll see you on the other side. Bye.